All right. First time going live on YouTube. We'll see how this goes. I'm going to admit Dr. Rashmi. All right. How do I mute myself? Okay. Sorry, guys. New to this. Thanks for joining me here. I'm going to pull up our amazing discussion questions. We're going to be talking all about managing acid reflux. All right, and here comes Dr. Rashmi. Hi, how are you?
Hey, what's going on?
Not too much. How's your day been?
It's been good. I'm obviously sitting on my floor right now because there's no other place in my apartment right now that's like somewhat lit in a normal fashion. So
Totally understand. Yeah, no problem. Same here. So thank you so much. I know you're super busy, so thank you so much for taking the time to come and talk to us. I know a lot of people are really looking forward to this conversation. And if you're not familiar with Dr. Rashmi's work, I'm going to give a little bit of a background and then feel free to add kind of what you do and what your specialty is. But Dr. Rashmi is a gastroenterology fellow at Stony Brook Medicine in New York. She's a native New Yorker interested in advanced therapeutic endoscopy and bariatric endoscopy. She completed her medical school at SUNY Downstate College of Medicine and internal medicine residency at the Albert Einstein College of Medicine in the Bronx. And she has also been published in peer-reviewed journals. She's authored over 25 manuscripts. She serves on the social media boards for peer-reviewed journal GIE, which is Gastrointestinal Endoscopy. And she is very accomplished. She also has a very amazing social media presence where she educates lots of people on GI dysfunction and GI disorders. And so feel free to add any other background you want to give our listeners.
first of all, thank you so much for having me on this call and this YouTube live. I think this is the first time I'm doing something like this. But yeah, basically everything that you mentioned, I think hit it right on the head of, the nail. But I've just kind of ventured into the social media space about a year ago because I really wanted to share my knowledge on gastroenterology. And, a lot of people have very common symptoms of the GI tract. And I felt like, I needed to kind of help promote some of this knowledge that I have as, outside of my clinic, outside of the patients that were seeing me, and allow easier access for patients or people to get more evidence-based information. Because there's a lot of stuff out there, and, there's a lot of misinformation, and that just not only exists in the non-medical community, but it happens even amongst doctors and nurses. Yeah. And I feel like having the background that I have, I could really help some people answer some of their questions. And I also have a slightly unique perspective of medicine. I do think that there are, more holistic ways of looking at therapies, aside from, I'm someone who doesn't like to push pills at all. So I'm one of those, I like to peel off medications wherever I can, especially if I feel like it's not really helpful, or, the risks of the medication outweigh the benefits overall. And if there's like a better way to achieve the same goal. So I like to treat the cause and just not the effect. That's kind of where I come from. But Molly, thank you so much again for having me on this.
Yeah, no, I'm so excited about this because like you said, there's so much misinformation, and many of my subscribers here really struggle with acid reflux. I get tons of comments every day that they've been to the doctor, kind of dismissed, maybe given a PPI, maybe not, just so many different perspectives because acid reflux is so abundant. Ooh.
Sorry.
That's okay.
And then it happened. Okay, never mind.
No worries. This is my first time going live on YouTube, so I'm trying to figure it all out. But But anyway, it's just, it's a complicated issue. And like you said, it's really important to think about the cause, because there are many different ways to treat a GI disorder, as you know. So I'm really excited for people to have your perspective as a doctor who identifies and is willing to take a look at the root cause, and talk about some of those treatment options and different factors there. And of course, all my videos and this conversation always comes with a disclaimer that we're not advising you and the watcher personally. This is just kind of discussion and educational video on some information on acid reflux. So with that said, I'd love to start with some causes of acid reflux. This is a question I get a lot. And based on your practice and of course your education, what are some of the most common causes of acid reflux? And why are so many people struggling with acid reflux?
These are really good questions. So the first question I will address starting by saying that as human beings, we all have what we call physiologic reflux or physiologic acid.
Mm-hmm.
And what that means is that, you know, when you see food or when you think about food or it's around mealtime, your body does what it naturally does and it creates acid in your stomach. And when it creates acid in your stomach, it's preparing for that food to come into the stomach so it can start digesting, it can start, you know, doing the things that it normally does.
Mm-hmm.
So when people experience acid reflux, we're assuming that it's not physiologic reflux anymore, but it's pathologic reflux. And that's the distinction. The distinction is that they're either producing way too much acid that's required for whatever bolus of meal that they're anticipating or their body's anticipating, or they might be hypersensitive. And I can talk about that a little bit later. But these are kind of the two things that we think about when we think about acid reflux. Now, why do some people develop reflux and some people do not, and they're eating the same foods? No one really knows. And that's the short answer. But it's whatever trigger. So we talk about triggers in GI. So when, say, someone comes to me in the clinic and they're like, you know, I have all these symptoms and, you know, I don't know what my triggers are and I don't know how to pinpoint it. So we go over basically what their diet looks like from breakfast, lunch, and dinner, and even looking at like whatever additives people are using or like sugar sweeteners and stuff like that, coffee, peppermint, things like, so there are known triggers of acid reflux, and that's kind of, you know, basically avoid everything good and tasty, right? But that's not realistic. And I find that it's, you know, it's usually one or two things that are provoking someone's reflux, at least in the early stages, or like in people who can be controlled in lifestyle measures. So there are I would say there are three groups of like people who suffer from pathologic acid reflux. Those who can manage it through lifestyle alone, those who can manage it lifestyle and diet, but those then who can manage it with like low dose therapy, and then those that are super uncontrolled and they need to be on high therapy. And then from that, it kind of offshoots to like possible other causes of acid reflux, like structural causes or pressure related, motility related causes. So that's like a whole nother topic. But when you're talking about at least the early stages of acid reflux, that's what we're looking at. I think that might answer the question, but really the first thing to start thinking about, even before seeing a doctor for your acid reflux, which I mean, I think you should, if you're experiencing a little bit of acid reflux, because there are things about acid reflux that is it's not promoted. Like, people don't know that pathologic acid reflux, uncontrolled, can lead to all these other problems, and could be pretty serious problems. What I would say is actually keep like a food diary. So that's one thing I do recommend my patients when they first come to me, to keep a food diary of what they're taking and how much symptom they're having based on those meals.
Mm-hmm.
And then once we see a pattern, if there's a pattern, then we can kind of try to eliminate that part. But really, like, we don't try to throw the kitchen sink at this. It's a very individualized approach. Everyone suffers from acid reflux in their own way, and they have their own triggers. Again, no one knows why. No one knows why, this person, their trigger is caffeine, but this person can have all the caffeine in the world, but their trigger is, I don't know, tomatoes, So that's something just to be aware of.
Yeah. And within those triggers, I also think it's important to know how much amount matters. So it might not mean like you can never have tomatoes again, but just having them in a small amount and knowing kind of what your threshold is there, I think is important. Kind of like with FODMAPs. But from a nutrition perspective, I've some common causes, correct me if I'm wrong, but some common causes that we've talked about in my education as in dietetics is those with eating disorders. So sometimes eating too little can cause slow gastric motility, maybe resulting in some acid reflux, because so many people with anorexia do end up with gastrointestinal distress or IBS. And another one that I've heard is also binge eating. So having those big meals at one time can then potentially trigger acid reflux. Is that something that you see with those two kind of different eating disorders?
Yeah, so I think, they're at different ends of the spectrum in some, in some way, shape, or form, but they both can trigger very severe symptoms. And people with eating disorders can also have mood disorders as well. And that also can trigger abdominal symptoms. Like you mentioned, irritable bowel syndrome is very common in people who suffer from depression, anxiety, all of those different disorders. And really, when it comes down to it, there is a component of GERD that is related to really just the mind.
Yeah.
And we talk about that not so often. I get there once I've done all my testing and made sure like nothing else is the cause, because then that's really whatever is remaining. But even then, people who eat too much can suffer from acid reflux, because you're creating a larger bolus than your stomach is ready for. And it's ramping up all of this acid to try to digest whatever you've ingested. And it's just causing too much of an exposure in your esophagus. So whenever you're experiencing acid reflux, it's when that acid goes past what we call the lower esophageal sphincter. So there, at the end of your esophagus, there is a muscle, and that muscle is supported also by like a sling of essentially like muscle fibers on the outside that kind of keeps that sphincter tight when it needs to be tight. And people who have reflux or experience symptoms of reflux, it's when the acid in the stomach, the normal acid, whatever is existing in your stomach, is coming up and the esophagus is feeling it. So your esophagus isn't really used to seeing such a high acid load. It's used to seeing a little bit, and that's normal. But such a high acid load, that's when you start getting symptoms. And there are known triggers that actually people can develop normal amounts of acid in their, you know how we talked about people developing too much acid in their stomach, but there's also an entity or a part of GERD where you're producing normal acid, like whatever you normally should be producing, you produce, but that sphincter hasn't closed or that sphincter has relaxed. And basically that reflux is going, it's allowing the passage of least resistance. It's coming up, and things that kind of not weaken, but like loosen that sphincter transiently are things like caffeine or peppermint. or smoking. Those are the really main ones that cause kind of like loosening of that sphincter. So
Yeah.
those are some of the things, like when someone comes to me and complains of acid reflux, I ask actually whether they're smoking or not, and whether they're using non NSAIDs, basically. So NSAIDs. So medications like ibuprofen, Aleve, Motrin, those can also cause reflux and abdominal pain.
Great points. Yeah, super important. And so if someone is experiencing acid reflux, when they go to the doctor, do you normally check structural? Like, is there any way to check if the lower esophageal sphincter is like malfunctioning? There is.
Yeah, there is actually. So that's kind of the workup that we initiate if people aren't well controlled on the standard medications that we give them. There are certain indications that no matter what, we're going to go down that pathway. So the testing is called esophageal manometry. And really what that means is that a probe is inserted for 15 minutes. It goes through your nose. You get it with the motility lab with the gastroenterologist. It's a very specialized test, but you have a probe and it goes through and it kind of traverses your entire esophagus and it passes your lower esophageal sphincter and it measures the pressures. It basically measures the pressures of your esophagus. So you're given a food bolus or whatever, they give you some liquid to drink, and basically they track the pressures along the esophagus. And if your lower esophageal sphincter isn't relaxing normally, or if it's not tightening normally, then that'll be reflected on the test results. So that's one way to actually look at that, short of just trial and error.
Right. Yeah. No, that makes sense. So we've talked about high stomach acid, and I know that a conversation that's pretty relevant in the functional medicine world is this distinction between high and low stomach acid, and how sometimes low stomach acid can also cause acid reflux. Is that something that you would test for also, or sort of try to figure out with your patients?
So with regards, I know for you it's clients.
Yeah.
So with regards to low stomach acid, we actually don't think that low stomach acid is related to esophageal reflux or even physiologic reflux. There is a way to test it. There's a way to look at the pH of your stomach. It's not commonly performed because it doesn't really add anything more to your workup. It's like a test that you're like, okay, great, my pH is like 8 versus my pH is 4. But what does that really mean? Nothing. Because when you're discussing about reflux, a lot of it is symptom control, right?
Yeah.
People want to have a quality of life. So whether or not they have a low pH or high pH, it really doesn't matter. We actually use medications to try to increase that pH, so the pH is not as low. We use acid blockers, like, I'm sure you're going to ask me about it soon, but
yeah, I'm really excited to talk about those. Like, tons of questions about that. But before we kind of talk about that, it's interesting to me how many people see benefit from apple cider vinegar or apple cider vinegar gummies before a meal who struggle with acid reflux. And I'm curious what your thoughts are about that, because I see that being potentially helpful if you have low stomach acid, or potentially damaging if you have high stomach acid. So what are your thoughts there?
So this comes up a lot.
Yeah, I bet.
Apple cider vinegar comes up so much, and really, I think that the short answer is we still don't know. There is no good data. There are these self-proclaimed randomized control trials, but they have like pretty large biases within the context of the papers. What has been shown is that using apple cider vinegar can actually lower the pH of your stomach and can actually lead to abdominal symptoms, like other abdominal symptoms, and maybe worsen reflux symptoms. So we talk about symptomatic control. I actually ask my patients to completely stop that. if they're using even like teaspoon or like an aliquot of apple cider vinegar, I actually ask them to stop it. I know there's a lot of discussion about like the potential health benefits of using apple cider vinegar, but at least with this trials that we've done in the medical community, there's no strong data supporting that. And usually if someone does come to me with reflux, I ask them to stop it.
Interesting. Yeah, I dabble in a lot of different gut health podcasts just because I like to hear perspectives from different functional doctors and medical doctors. And I've been hearing this pop up again and again with the butane HCl being a treatment for acid reflux. And I find that so interesting, actually just capsules of it. And I think that's like a very interesting treatment modality that I guess has worked for people who are having discomfort with, who believe they have low stomach acid. I don't know if they've had that test, but anyway, I didn't know if that was being done in the medical environment. So I wanted to ask you about it.
No, we're not using betaine HCl. I know that there are kind of like supplements that are sold at the pharmacy and like GNC. My patients have mentioned this to me.
Yeah.
But I don't, again, I think with regards to that, it's hard to say whether it actually truly benefits. One thing I will say, if like you are taking something like that's a supplement from that has like, ingredients that haven't really been studied that well,
Yeah.
it's important to make sure your liver tests are being checked with your doctor, because a lot of these can cause what we call drug-induced liver injury and can cause really severe like liver problems. So and it's not uncommon that I see someone who's on like some, maybe natural or holistic med or something they found at GNC, and they're coming in with like really high liver numbers. And it's really scary, I think, sometimes. But what I would say is like it does a lot of the betaine HCl also has pepsin in it, which is like an enzyme, like active version of an enzyme, and it breaks down food basically in your stomach. So if it's just those two, maybe it's probably not bad, but it's not something I think I can endorse or like not endorse. I just feel like if you are going to plan to take it, just make sure you let your doctor know, and then they can just make sure your like labs are okay.
Yeah, that makes total sense. And the supplement industry in general is unregulated. So it's one of those things where you have to be really careful about what you take. There are so many supplement and drug interactions as well. So it's definitely something that you want to be guided through and make sure that you're getting well-sourced supplements always. So one more thing before we dive into the PPI conversation is, when do you think someone should see a doctor if they struggle with acid reflux?
So this is such a good question. And I feel like everyone who's listening in right now should really listen in carefully, because with reflux, particularly, so we talked about pathologic reflux, right? And when that happens, your esophagus is seeing more acid than it normally should. When that happens, the cells in your esophagus can change. Like they can have inflammation. So, we talk about inflammation in the gut, right? And if there's chronic inflammation, there's recurrent inflammation, if there's recurrent injury, the cells turn over more and faster. With faster turnover of cells, there's a chance of cancer. And people who are otherwise normal, healthy, young people, most of them don't need endoscopies unless they have certain alarm symptoms that I'll talk about. But basically, people who, I think everyone who has reflux should go to a gastroenterologist. I'm just going to say it, because yes, primary care doctors are equipped to treat reflux, but I feel like if it's not responding to like low dose therapy, like even a Pepsid, and like you're still having symptoms, it's worth going to a gastroenterologist, because we screen for additional things. We ask more questions to try to figure out whether a person needs to have an endoscopy. So that's the next step, right? Whether someone needs to have an endoscopy.
Right.
An endoscopy, just for your listeners, is a procedure where we take a long flexible tube with a light and camera at the end, and we look internally at your esophagus and your stomach and the first part of your small bowel. And we look for things like inflammation. We look for things, abnormal cells. We take biopsies. And people who need endoscopies are the following: if you have anemia, if you have trouble swallowing or painful swallowing, if you have abnormal weight loss or unintentional weight loss, if you have persistent vomiting or nausea, if you're over the age of 60 and all of a sudden you now have acid reflux, that is something that's, just by that, we do an endoscopy.
Mm-hmm.
People who also see blood in their stool. So if they're seeing like black stool or bloody stool, that's something that we definitely need to go in and we'll look with an endoscopy. People who have abdominal pain with their reflux, they could have an ulcer. That's something that we use. And then people who have actually a family history, like a gastrointestinal cancer in a first degree relative, or if they have like a personal history of like other types of cancers, like uterine cancer or breast cancer or pancreatic cancer, or they have family members with these types of cancers, because sometimes GI cancers, actually a lot of times people who have these types of cancers can also have GI cancers. So these are the reasons why we would decide to go in and look with an endoscopy. Untreated pathologic reflux can lead to more things, not aside from cancer. It could lead to strictures. It could lead to just chronic inflammation. People get sometimes, like, not to scare anyone, but like, sometimes we have to resort to surgery because the strictures are just too bad, from the chronic inflammation and the chronic scarring down. Things that also increase your risk for esophageal cancer are if you are white, male, smoking, over the age of 50, and actually obesity. Obesity is an independent risk factor for esophageal cancer and reflux. So we talk about modifiable risk factors, or things that people can do lifestyle wise to reduce their risk of reflux. And actually, weight loss is one of the proven ways. If there's weight to lose, safely,
Yeah.
that has been proven to improve reflux symptoms.
Mm-hmm.
So if we're talking about lifestyle, like outside of supplements, outside of GNC and all these other, companies telling people to take their supplements, that in itself will help reduce your risk and reduce your symptoms.
Mm-hmm. So I'm going to be selfish for a second and just use myself as an example, because I think a lot of people might also be in this situation. So I get so many comments about people on a PPI, didn't help. Maybe they went off of it, still having symptoms. And my experience, I was on a PPI for over a year, helped me for a little while, and then I decided that I wanted to ease off of the PPI. I didn't want to be on it forever. And by no way is this conversation like shaming PPI use or anything. I used it for a while, and it was very helpful for me.
Yeah, it's the right thing to do. It's actually the right thing that you did come off the PPI. If you had like urgent or important reason to be on it long term, we actually advise people to come off of it after surgery.
So it was so hard to come off of it, and I'm sure that this is something that you see. So coming off of it, I really utilized a couple of different herbs that I've mentioned in some of my other videos to stop and kind of build up that mucus layer. And I don't have by any means like the symptoms I used to have. Like I used to have debilitating symptoms, but I do still have like occasional, like maybe like once or twice a week, a little bit of burning. And so when would that qualify as like the untreated, the kind of like mild symptoms a couple times a week? Is that the untreated type of acid reflux that really should be somehow addressed in order to prevent like Barrett's or anything, like any other issues? Or is that on the safe side of the spectrum? Like, I'm curious where that falls.
So that's actually a really good question, because I think when we talk about controlled reflux or like non quality of life affecting reflux, first of all, it's actually pretty subjective. Like if that's something that you're okay with experiencing, then fine. If it's over 2, or if you're having night symptoms and all the other things that we're talking about that I just mentioned, then no, it's not good. But people who do have reflux and they were previously uncontrolled on medication, it's worth taking a look in their esophagus and seeing what's going on. Because say like you come off the PPI, which you did, and rightfully so, because no one should be on PPI long term unless they have like very specific indications. But I'm assuming you probably didn't have any of those indications, which is why you didn't need to stay on the PPI long term. But people who do have those indications, they should be on the PPI long term. But and it depends. And whether you or not you should be on the PPI, or if it's like worrisome, depends on what your endoscopy looks like. If your endoscopy is completely normal, if your esophagus looks completely normal, there's no changes and your stomach's fine, yes, there's no issue. Then it comes down to symptoms.
Yeah.
Are you okay with that symptom, having that symptom once or twice a week? If you're okay with it, then we're like, that's pretty much it. But that's kind of where we are with it. But one thing I do want to say is that we do have people who don't respond to 1 PPI or 2 PPIs or 3, or even the 4th one that we have on the market, and some of the new ones. But we have to also look at a couple of factors. One is, was there a trial? Was there a meaningful trial given for the drug? And that is usually 8 weeks. We give 8 weeks for medications to work. If they do not work at whatever dose, then we either escalate. If you're at maximal therapy, then we switch. Some people have an enzyme in their liver that metabolizes some of these medications differently, so they don't work. And then we have to change them. So sometimes like esomeprazole might work for some people because it's the enantiomer of omeprazole. Yeah, and that's why some people are like, only this, trade medication works for me, and the one that you're prescribing me that my insurance covers doesn't work for me. And that's because of that liver metabolism, cytochrome P450. But that's one thing. So then people who still have symptoms despite changing classes, despite being on maximal therapy, there is a test that we do to see if this is actually true acid reflux. If your symptoms correlate with actual events of acid reflux. And the way we do this is by 2 methods. One is the not so comfortable method, and the other one is pretty comfortable. One of them is the catheter. Same catheter that I mentioned earlier, where you put a probe down and it measures basically your acid exposure over 24 hours. So it's like a tube in your nose for 24 hours, and people don't like it because it's very uncomfortable and it's like kind of annoying. So there's another way we can do that. It's called the Bravo test, and really, it's like this tiny little implantable device that we kind of pin to the. It sounds painful, but it really isn't, because you don't really have receptors there. But we pin this tiny device that falls off on its own. You poop it out on your own. Like, you don't need to retrieve it, whatever. But it's attached to a device, external device, that every time you experience a symptom, you click on the device, and then that device in your esophagus is monitoring basically the acid exposure. So when it comes down to actually analyzing the data, it looks at, okay, this person said that they experienced heartburn at this time point. What happened in the device in the esophagus at that time? Was the pH really low? Was there a lot of acid exposure in the esophagus? So it looks at whether it correlates or not. Then we could be like, okay, this is true acid reflux, or it isn't. And there are people who have this, and that we talk about hypersensitivity, and that's where that hypersensitivity condition comes into play, where their symptoms are not correlating with actual true high acid events in their esophagus. So then there are therapies for that.
Interesting.
But that's kind of, I mean, I digress, but like, this is kind of basically the way we evaluate people with acid reflux. So acid reflux is not just after acid reflux. It's like this whole thing. And there are a lot of different names for all these different, subtypes of symptoms that people can experience.
That's really great information, because from what it sounds like on some of the messages and comments I've received, it sounds like it can be such a discouraging diagnosis when the medication doesn't help. So it's good to know that there's other things to ask for when you go to the doctor, and there's other tests if medication or other medications, trying different ones, isn't working for you. Speaking of medication, I'd love to talk about the reason why maybe PPIs are not meant to stay on forever, positives, negatives, anything you want to share regarding proton pump inhibitor use.
Yeah, definitely. So usually for people who don't have very significant symptoms, but they have acid reflux, we don't start on a PPI. We actually do something called the bottom-up approach. So we start with like over-the-counter stuff like Tums, or like, like calcium carbonate or sucralfate, or things like that, bicarb, stuff that you mentioned, like building your mucus layer kind of things, and then lifestyle. When that doesn't work, then we bump it up to H2 blockers, so like Pepcid and ranitidine before it got pulled off the market, but Pepcid is one of them. Cimetidine is actually pretty good too. But that's what we start off with. And again, these are for people who don't have alarm symptoms that I mentioned earlier, or people who don't have significant symptoms of reflux, but they have reflux. Like it's a quality of life issue for them. And then we go up to PPIs, and then, kind of that's where we start playing around with different PPIs. So first of all, it depends on patient preference. If someone doesn't want to go on medications, and I have a good amount of people who do not want to start medication, and assuming everything else is fine, and I'm not concerned about what's happening in their esophagus, and I need to look in there, I'm not concerned about whether or not they're on a PPI, but I do give it a trial, and I go over each risk profile with my patients. PPIs in general, at least in the short term, no issue. Really no issue. I actually have patients who've been on PPIs for like 40 years now, and they've had no problems. There is data, though. There is data about long-term side effects of PPI use. So some of them are increasing the risk of one of this these types of GI infections called C. difficile colitis. That is that has been correlating with the use of long-term PPI use. And when I mean long-term, I'm talking about like years. I'm not even talking about a year. I'm talking about like 5-10 years. You know, people who have a history of C. diff should not be on PPIs generally. If their C. diff is controlled and it's way in the past, then that's fine. PPIs can also cause certain like allergic reactions in the kidney. They're like allergy type reactions, but it can cause one of those. It can cause electrolyte changes like low magnesium, but again, that is not the relationship isn't super strong when it comes to that, but it has been seen. So whether it's causal or not, we don't know. And then PPIs also, so this is a causal relationship. PPIs can cause what we call microscopic colitis. It's a pretty benign condition, but it can cause like loose stool, like people have, it's a quality of life. Again, you know, there's no increased risk of like cancer or anything like that, but it can cause like this type of colitis that we can't really see. Sometimes we can, but most times we don't see it. And then we take a biopsy and it comes up what we call microscopic colitis, and then we treat it. But those are kind of the you know, quote unquote side effects, long-term side effects of using PPIs. In the short term, no issues. And even with my long-term patients who are on PPIs, most, I think about 95% of them have had none of these problems ever.
What about nutrient deficiencies?
So there is a discussion about whether it causes nutrient deficiencies. Anecdotally, and even currently in the data, there is nothing to support that. It might be that, you know, people have gastrointestinal conditions, like underlying gastrointestinal conditions that might exacerbate some sort of like nutritional deficiency, but there is no causal relationship between PPI use and nutrient deficiencies.
And what about the long-term impacts on brain health? I think that there was some data that came out that I don't know if it's since been clarified about like dementia. Can you speak to that a little bit?
Definitely. So that's actually a really common question I get a lot about the possibility of dementia, and there is no correlation between the two. The paper that came out on that on PPI use and dementia has been debunked through further studies. So it's not it's even people who have dementia are on PPIs. Like there's no increased risk at all.
Okay, last question about that. What about constipation? So I definitely experienced constipation when I was on PPIs. Is that common? How can someone also avoid that symptom?
Constipation, I don't see it very often actually. With the patients I see, it is a side effect, but you know, it's a side effect that you read about, but like I feel like I haven't really seen it. If you want to combat constipation in general, I would say stick to a high fiber diet. Fiber actually, you know, as human beings living in a first world country, we pigeonhole our minds into thinking that we need protein. So we take in 30% more protein than we need, but then that 30% gets taken off from the fiber category. So we don't take enough fiber. And when we're talking about like overall gut health, and this actually goes along with symptoms of reflux, because, you know, when you're talking about gut health, you're talking about the gut organisms, not just bacteria, but like the diverse population that is supposed to exist in your GI tract. And having a well-sourced, varied fiber diet helps you combat all of those things like constipation, diarrhea, like any GI symptom that I think can really improve with a high fiber diet.
I talk about fiber a lot, and I think that people have to find their sweet spot with fiber. So like people with IBS and gut dysfunction, there's some people who are not eating enough fiber, which is resulting in an ineffective evacuation and buildup of waste. But then there's also people who may be eating too much fiber. And so it's really, and that can actually stop you up as well. So it's like really important to kind of find that sweet spot, and really important for gut health that you're getting that wide variety, like you mentioned. That's that prebiotic fiber, which in my opinion is way more important than any probiotic. Well, for some people that's different because there are some probiotics tested for specific issues, but that those prebiotic fibers are really, really important. They're food for your probiotics.
Yeah.
So super important.
For your gut, for sure.
Absolutely. So we got some submitted questions, so I want to make sure that we get to those, and I don't want to take up too much of your time. So as far as like lifestyle tips for someone who isn't taking a PPI, how can they manage GERD without taking a PPI?
A couple of things, kind of just rehashing whatever we talked about. So if you're taking NSAIDs, ibuprofen, Aleve, Motrin, naproxen, stop it. Or if you really have to take it with food. If you have some extra weight that you want to lose, I would definitely go down that route, and not just for your weight loss, but also for your overall general health. That'll help with your reflux. There are some things that you can do, like lifestyle wise, like you can sleep at 30-degree angle in the bed. It's a little uncomfortable. A lot of people don't like it. These are proven things for treating lifestyle treatments for reflux. And then I really stick by a food diary and symptom diary. So if you have a symptom diary or food diary and you write down everything that you're eating, including whatever ingredients that there are, and then correlating them to your symptoms, then I think that will give you a lot more information about your individualized trigger to your reflux. Because, someone can't, I feel like even a doctor, whoever is taking care of you, is not going to be able to be like, okay, cut all of these things out, and then your reflux is better, but then you have a crappy quality of life because you can't eat anything great, or like palatable. So I think these are things to definitely focus on. If you're smoking, alcohol, cut it out. Wine, definitely not. It's hard, I know, but like I think these things really add to people's symptoms. Caffeine, chocolate.
I know.
We all love chocolate. But, those can cause and even like some people even like chew gum. So you know how some of the gums have like these artificial sweeteners?
Yeah.
Those artificial sweeteners can relax the pressure of the lower esophageal sphincter that I was talking about earlier, and that can cause reflux. So these are all the lifestyle things that you can do to improve your reflux. Also, another thing, there's two more things actually. One of them is tight-fitting clothes. If you have very tight-fitting clothes, it can really press on your abdomen and worsen your reflux symptoms. The other thing is eating before bed. Give it 3 hours.
Totally.
You must give it 3 hours. Sit upright. That's something that I can't express enough. I mean, these are things that like lifestyle. Again, it hasn't really been proven in data, but anecdotally, and I think it's across the board that these are some of the recommendations, and people actually respond to them. So I think I would say like that would be my major lifestyle stitch.
Yeah, that makes total sense. All of those tips have significantly helped me. And you mentioned wine, and I have to ask, would you recommend any other types of alcoholic beverages over wine, or is it all alcohol, or is wine specifically bad for acid reflux?
I would say wine is particularly bad
Mhm.
in terms of symptomatic reflux.
Okay.
But um, even certain types of hard liquor like vodka, rum, gin, you know, I don't know if this is true, but I feel like whiskey and bourbon, not so much. People don't really have symptomatic worsening of their symptoms. Again, it's super individualized, so some people might feel worse on it, some people not. But like wine, definitely, it's like fermented grapes. There's a lot of acidy component to it. So
Got
um,
it.
that might be something just to kind of avoid until like, you kind of figure it out. And I feel like with triggers, it's okay to try to reintroduce these things into your diet gradually in the future. But
Yeah.
if you're really suffering symptomatically, then like just cut it out. And then, it's kind of like the FODMAP diet, right? You're not
Yeah.
like a FODMAP diet forever. Like it's just like 2 to 6 weeks. And then, you know, then you reintroduce stuff in your diet.
Yeah, super important. Yeah, definitely. Um, and as far as other triggers, we got lots of questions about specific foods. So I kind of want to just like run through them and you can say your opinion on whether or not they're a trigger.
I feel like yes, no, yes.
Okay, perfect.
No.
Yeah. One of them is citrus. I agree. I agree. I think citrus is a tough one. Jams.
Depends on what's in the jam.
Yeah.
So if it's like more of berries, maybe not so much. But again, some people, it's like I would say like plus minus.
Yeah. I know some people have a hard time with like the more acidic berries, like raspberries. But it's all about amount, in my opinion. Like if you're gonna have a ton of jam that's very acidic, potentially.
Yeah.
But it's I think like 1 tablespoon with some toast is probably not gonna throw you off balance, but everybody's different. Cinnamon.
I feel like it's fine. I'm okay with people taking cinnamon. I haven't really found that many people suffering from cinnamon related like acid reflux.
Mm-hmm. And I also wanted to, also we had one more question that I want to, this is a great one. So this is one that, also I can help answer, but tips for individuals who are suffering from unplanned weight loss with GERD.
See a gastroenterologist, get an
Yeah.
endoscopy. That is paramount. If that's happening, you must see a GI doctor and you must get an endoscopy. And I can't even say this enough, but yes.
Yes, and a registered dietitian. Because
Yes.
if the cause is not getting in enough food, then a gut specialized RD can really help you with that.
Yeah. Once you've ruled out anything crazy in the esophagus or stomach, then yes, working with your gastroenterologist, working with a nutritionist or dietitian is really important.
Absolutely, yes. Because it can be hard to get in enough food with the triggers if you're having symptoms. I've definitely been there, and that's super challenging. Okay, the last thing I want to ask you about is herbs for acid reflux. So I personally have experienced so much benefit from them. I'm particularly slippery elm, licorice root, and I'm curious if you've ever seen people take them, or what of course sourcing is really important. Like you want to make sure that you're getting something that's lab verified and hopefully NSF, if you can find it. But what are your thoughts on that?
I actually don't know too much about herbs and acid reflux. I feel like my general approach to it is if it works and if it's not causing any harm, then fine, you continue it. But maybe you can actually teach me something about this. I think it would be helpful for me to know, like, you mentioned licorice root and
Yeah. So licorice root and slippery elm, I kind of just like I read tons of research articles on acid reflux, and there's not a ton of research on herbs, obviously, because there's not a lot of money there to test like if these really work clinically. But I did find some data on these herbs, even some in my nutrition book. This was while I was an undergrad. And so I was like, you know what, why not? I'll give it a try. I don't want to be on this PPI forever. So I asked my doctor if it was okay. He was cool with it. I kind of just experimented on myself, and with my doctor's help, of course, because you should never go off a medication without talking to your doctor first, I started to decrease my omeprazole and mix in some of these herbs away from the medication because they can bind to the medication. So I was really strategic about, I would have my herbs in the morning, and then 2 hours later, I would have the omeprazole. And so I was taking them, and they helped me 10 times more than the omeprazole did, because even on the omeprazole, I still had symptoms. It was better, but I still had symptoms. And so I started to have less and less and less pain. And I was also going to the bathroom a lot better. Things just were moving better through my GI tract. And it was like solid, well-formed. It wasn't like diarrhea or anything like that. But so anyway, I saw a significant improvement, was able to wean off my medication with those herbs. And they actually make a really great tea. There's this tea brand called Traditional Medicinals. You've probably seen it. It's like everywhere at Stop and Shop and Whole Foods. They make a tea called Throat Coat, and it has slippery elm in it. And so if I have symptoms, I'll either take a couple of the slippery elm, one slippery elm and one licorice root tablet, or I'll drink that tea. And how the herbs are supposed to work, from the research that I've seen, is that they help to lubricate the esophagus and help your body to create more mucus so that you're protected, sort of like sucralfate, which I also did take and saw a little bit of benefit, but that was like a short-term therapy. But anyways, they are generally recognized as safe by the FDA. I've looked into some things about them. There is like an interaction if you're on blood pressure medication. So like that's the only thing that I found, but they're supposed to have like anti-inflammatory benefits, antioxidant benefits as well. So yeah, I mean, I've kind of just been my own guinea pig with that, and it's nothing I would ever like recommend to someone that I didn't know. And like, I would never say like everybody should take this, because everybody's individual, everybody's journey is so different. But yeah, it could be something to try, because even if you just go look at the Amazon reviews of these supplements, it is like thousands of people like, saved my life, don't have acid reflux anymore. So I gave it a try, and honestly, I'm so glad, because it was, like you mentioned, it's quality of life. And like my quality of life was, I couldn't go out to eat because I needed to eat dinner so early. I couldn't have alcohol. I was anxious about symptom. Like it's a super tough thing. So I think that this conversation was really, really helpful. And thank you again for sharing your insight. And this was great. I'm so glad we were able to connect.
This was so enjoyable for me as well. Just getting to talk to you and learning something new, and having your listeners listen to us chat away about acid reflux. But I really applaud all of your efforts, and I really everyone else who's really listening or watching this, like, if you do have any further questions, I think from a medical standpoint, feel free to like reach out to me on my platform. Molly's amazing with her platform. I really like what you're doing on Instagram, and really for your community, and advocating for this very terrible disease sometimes. But yeah, thank you.
Thank you so much. Right back at you. I'm so glad that we were able to talk about this. I think it's one of those things that so many people struggle with, often silently. So it's just cool to kind of shed light on it, and so people can watch this and know they're not alone. And I'm sure lots of people are going to watch this and really learn something valuable. So thank you so much. And will you share where people can find you if they want to connect or learn more?
It's on Instagram at Dr. Scopes with Guts. I don't know if there's any way to type that for people.
Yeah,
but
I'll put it in the show notes.
Oh, great. Okay. And I think Molly, on your current stories today, you posted that and you tagged me. So if you want to go there, you can as well.
Yeah, totally, totally. I will link your information down below so people can find you. Thank you again so much.
This is so nice. Have a good night, everyone. Have a good night, Molly.
You too. Talk to you